Good afternoon here in Arizona and everywhere else, I guess, because we are at the end of the bottom of the time zones in the US. Welcome to another day of Research Nexus, where we have our very own alumni, Dr. Daniel Ebbs, come to teach us about things that the wonderful things he does as a part of his research at Yale, as well as his nonprofit that he started called MGY. I'm going to introduce Dr. Ebbs briefly for people who don't know him, and then I'll let Dr. Ebbs take away from there. Dr. Ebbs is a pediatric critical care attending at Yale and a postdoctoral researcher in the Capello Lab. He's an affiliate faculty of the Institute of Global Health and Yale, Uganda, where he was recently. He also serves on the Yale Global Health Council and is the assistant director for the Pediatrics Global Health Track, and is a co-founder of the Yale Global Health on Tap. He's a co-founder of MGY, the Laro Quo project in northern Uganda, and the MGY team leader for clinical applications of projects. He has worked in emergency medical services for over 20 years and continues to work in emergency medical services in medical direction and training. Dr. Ebbs earned his MS in community health at the University of New Mexico, and his MS training focused on the role of community health workers in rural and developing regions around the world, specifically in Western Borneo and northeastern Peruvian Amazon. His research interests include community participatory research in global health and pre-hospital predictive modeling, which he's going to talk about today. He's currently finishing his second year on an NIH T32 and is funded by the Yale Pediatric Scholars Award for Young Investigators. Welcome, Dr. Ebbs, and thank you for being with us today.
Thank you so much for the perfect introduction. Let me screen share and get started. Thank you, everyone, for being here. Give me one second this way. Hopefully not making anyone too dizzy here. Okay, of course it would be better to be in person in the future. As things start opening up in the next few years, it's always nice to be in person and meet everybody. But this is great. It's really nice to have the opportunity to present my research. And the one thing I think you started off with is I am alumni. I didn't put that. I put my MS because it's focused on the research I'm going to talk about with community health workers, pre-hospital predictive modeling, and the like. But I am alumni, and so that's something that I probably should have highlighted more on there. But I'm going to go ahead and get started. So my research focus is on developing a pre-hospital triage algorithm in limited resource settings to identify children who are at risk for serious illness. And broadly, my research interests are in global community participatory research design, a form of implementation science, and also the implementation of community participatory program development models. We have different program sites across the country, including Guatemala, the Northeast Peruvian Amazon, Northern Uganda, and then there's some sites in country that we have participatory programs, such as Chaparral, New Mexico. We had one in Madera, California, among a few other sites. It's hard to talk about my research without giving some context and background to me personally. I was a pre-hospital provider for many, many years. For those of you who are familiar with the Central Valley, that is where I worked initially. And Central Valley is very rural, and it's a very busy 911 system, but you work, I was out of Fresno, but I was working after my first year and a migrant town outside of Fresno for many years, and witnessed many of the health disparities associated with not having or looking at what happens when you don't have access to quality and affordable healthcare. And so, as you can imagine, year after year, you start to get more and more frustrated. And I got to the point where I decided to go back to school, graduate school specifically, and learn about health disparities. And 2011 was a great time to go into graduate school in community health. I feel like the health disparities research was really starting to take off. This is my mentor and advisor, Dr. Magdalena Avila. My first day in class in graduate school, she showed the documentary Unnatural Causes, which talks about, hierarchical medicine and based on your job, how you're more at risk for coronary artery disease, and talked about like the Pima Indians and a lot of how resources can be attributed to health outcomes. And immediately let's just say I had a conversation with Dr. Avila after class and we spoke for multiple hours. She grew up in the same community in Central California that I was working as a paramedic. She was a farm worker and she went back to school to UC Berkeley to study community participatory research. She marched with Cesar Chavez. She's one of those people that lights up the room when she talks. And so we just connected, and this transitioned into a strong relationship that we still have to today. I became her TA, teaching assistant, and research assistant over my 2 years in graduate school. And she is responsible for a lot of my interests in community-based participatory research, which the University of New Mexico has a site. She primarily worked in the South Valley with health promotoras. However, she was working on a large grant in Chiapas, Mexico, and the Peruvian Amazon. My project for graduate school was to undertake the program in the Peruvian Amazon to work with the health promoters in that region, which was a phenomenal experience. I lived down there for a summer and completed my research for my degree. My interest was, how can you elevate health education with mobile health? You're probably thinking right now, mobile health, it's ubiquitous, especially, you travel somewhere. I was just in northern Uganda and everyone has cell phones. Well, if you could imagine 10 to 15 years ago, it was like the access was significantly less. In addition, the cloud capacity to store data, for instance, if you were doing research on health surveillance, or if the community health worker wanted to upload things from the internet, it was really challenging in some of the areas specific to where I work. In the Peruvian Amazon, it's still really difficult to get any type of internet access or phone access. In Uganda, we have access, but it wasn't always there to the same capacity. Because what we really want is to be able to store data and then to access it once there's an area that can sync, that has access. And so we can kind of provide real-time monitoring. And so my research interest was, how can we use a community-based participatory research design to use mobile health for public health education and disease surveillance. And it was a great combination of different things happening at the time. This hot topic of using community health workers for providing healthcare in limited resource settings, using CBPR with mobile health and this new technology through ICT Edge that's able to store data remotely and then sync for people supervising, like I had just discussed. And so this was something that I was able to focus on for my master's degree, and then extended into my nonprofit organization, which is right here. We'll see if the link works, but MGY, which really is just a way that we could continue to provide health capacity with training community health workers using community-based models. So a train the trainer model to help communities develop their own community health programs, of us providing oversight and some health education initially, and then working with transitioning the programs to be sustainable. And so moving that background, so I kind of did a full circle from working pre-hospital to learning about this community health, or getting a degree in community health and community-based participatory research experience, to going to med school, residency, fellowship, and now as an attending, I'm doing research in pre-hospital. And this kind of, the rest of the talk is really focused on the research interest for one of our program sites in Uganda, which is to develop a pre-hospital algorithm for identifying which children need to be triaged early. And so I will start with this. And so it's important to realize that over half of pediatric deaths in low and middle income countries are in the pre-hospital setting. Over the last 3 decades, we've seen a significant decrease in pediatric mortality rates. This is primarily due to socioeconomic development in the regions that had really high mortality. And this is from things like the Global Development Fund that have moved people from extreme poverty to just poverty. There still is, as you can see, a significant amount of unnecessary death in pediatrics in this region. And the other focus that is partially responsible for this decrease in mortality is pediatric focused programs in limited resource settings. So the World Health Organization started what's called the IMCI, which is Integrated Management of Childhood Illness Programs, and that is to train rural health facilities to identify sick children early and really have focused training and programs for kids, including getting them immunized early. This transitioned in the early 2000s to something, I wouldn't say transitioned, but something that kind of budded off of the IMCI was the ICCM, which is what I'm very interested in. And this was using community health workers to provide 3 levels of care at a community level where there's very limited resources. Those are treating pneumonia, malaria, and dehydration, where there's like very limited health access. So they would do a RDT or rapid diagnostic test to see if malaria is positive, and then treat the malaria if the child is positive. They would do a focused respiratory exam and treat pneumonia. If their malaria is negative and they have a positive respiratory exam, or if the patient's been dehydrated, they'll provide oral rehydration solutions and zinc, either prior to referral or not refer and follow up. And so the ICCM is a program that was developed through the WHO's IMCI that is more expert. We call like developed by experts without much evidence. So we don't really know if this works, but we think it does because expert opinion says, you know, we're treating kids in the pre-hospital setting, but it's very low on the tier of evidence. This is a triage algorithm we had for one of our programs early on during my graduate school that could use like you follow an algorithm and it would tell the community health worker whether they needed to treat or refer. And this is kind of a modified ICCM. So to understand the research that I'm working on, it's important first to look at the area that I work. Global health is very heterogeneous, so it's difficult to understand the research unless you understand the demographics and some of the other like health resources in the region. And so I work for this research project in northern Uganda. If you don't know where Uganda is, you first find sub-Saharan Africa, so south of the Saharan Desert, and then you find Lake Victoria, which is the largest tropical lake in the world, and that's right here. From there, if you go northwest, that's Uganda right there. And I work in northern Uganda in Padere district. And to travel there, it's about 32 hours of moving time, meaning not layovers, not stopping for gas, not arriving to the airport. Just the actual time that you're traveling is about 32 hours. It's about 2 days to get there. And then once you get there, obviously you're in a delirious state and pretty exhausted. For those of you who travel a lot, you understand what I'm talking about. But it's a very it's a rural place to get to. After about 8 hours of driving, you hit dirt roads, which is one of the barriers to some of the health resources there, or getting to adequate health resources. The areas that we work have very high infant mortality. Some of the numbers we see in the US, 1 to 3 per 100,000, we see 1 out of 10 in the northern part of Uganda. And this is under 5 mortality. Anytime you hear pediatric mortality, you have to ask one question, and that's, what are they including? Because neonatal mortality takes up a huge percentage of pediatric mortality. So you say, you know, infant mortality, child mortality, under 5 mortality, all these things you just have to know what they're talking about. Because like the 1 out of 10 number is pediatric under 5 mortality. And so once you take the neonatal mortality, you'll see it's more like the 30s to 40s for the most recent number per 1,000 for pediatric mortality, or sorry, for child mortality. But the actual under 5 mortality could be something like 102 per 1,000 in this region. And the numbers are really difficult to track. Surveillance is hard the more limited resource setting you're at. Just because getting accurate data can be really challenging, especially when you have health disparities and really low social economics. And the other thing that is important to recognize is these more rural regions of higher mortality are also associated with other health disparities, such as drinking water, for example. When children are dying from, you know, preventable causes like dehydration, pneumonia, RSV, malaria, the primary treatment is supportive care plus or minus antimicrobial therapy. But if you can't provide adequate supportive care, you're kind of stuck. And so you can see on here, like 1/3 to 1/2 in some of these areas don't have clean drinking water. So it's really hard to provide the care you need when you don't have the resources. This is from my last trip there 2 weeks ago. So once you hit the dirt roads, there's no transport system. And where we work is far from any regional hospital. And so you can see the roads here. They just flood really easily. It's really dangerous. You can't travel at night due to safety concerns that are other than the terrain, but the terrain can get really challenging. You're going through flooding, rivers to the roads, really big ruts. And so that's just an example. And as I mentioned before, the mortality rate where I work is more in the 30s. 1 out of 28 children between this age range, which is 2 months to about 5 years of age, die before their 5th birthday, 2 months to 5 years, which is still a very significant mortality rate. And that's from data in 2016. So that we haven't seen a new Uganda health demographics data set. We have a partnership in the area from many years of working with a community health worker program there. And so it's important to know when we're talking about creating a predictive model to identify kids in the pre-hospital setting, we have underpinning all of this a community health worker program that is community-based using a train the trainer model. Community health workers are called village health teams in northern Uganda. And this model, for sustainability reasons, was developed early on and continues to expand with the village health team leads developing ongoing curriculum, education, and leading the program. And so having this in place really helps when you're working in the pre-hospital setting on research, because there's many barriers to trying to get accurate data in the pre-hospital setting. And if you don't have well-trained health workers in addition to infrastructure in place, it's impossible to do this type of research. And so the problem is high pediatric mortality or death in this area. Specific to the setting, there's no pediatricians, there's no advanced pre-hospital point-of-care tests in this region. There's no real way to identify which children are really ill unless it's late signs, like the danger signs that the WHO has in place. And then we have the infrastructure there that I just mentioned. And so the big point to my research is that there's no pre-hospital risk assessment score for limited resource settings that exists right now. I'm going to talk briefly about a few of the scores that exist in rural clinics that have been validated in sub-Saharan Africa. And these scores are something that my research is hoping to see if they can cross over from rural clinic to pre-hospital. But you have to understand that it's a completely different environment. By the time a family brings a child to a rural clinic, it's a completely different data set, because the resources, the input, and how sick they are, it's typically families, at least many of the locations I work, wait till the very last second to actually put the resources, when most of the resources go to, for example, food, to put resources into traveling to a larger clinic or hospital. And so it's really difficult to look at these scores that have been developed in sub-Saharan Africa at clinics and translate them to a pre-hospital setting. And that's what I look to do. And I'll talk about some preliminary data in a pilot project we just finished for doing this. This is one of the scores. This was used to detect severe malaria, with the outcome being mortality. And the 3 clinical exam findings they looked at were prostration, coma, and deep breathing. And they had very good accuracy for doing this. But if you're in medicine, you look at these 3 signs, they're very severe late signs. So it's really obvious that would these signs would allude to from a clinical standpoint. That score was validated looking in Uganda at children who presented sick that were without malaria, and it also showed good accuracy, which was kind of the first question you might have with the LOD score is, has it been used for something other than malaria? And it has, and it still has good accuracy when you look at it. I'm not sure if you're familiar with ROC curves, but they're a great way to see how accurate your model is. The top part is sensitivity and your true positive rate, and your bottom is your specificity or your false positive rate. And if you follow this line, if your curve, you see this curve here, if your curve was along this line, then it'd be like flipping a coin. The test really not have a lot of significance, but if the area under here increases, then your accuracy will increase as well. And so when you see something like 0.8 or above, then you're starting to have something that can really predict well your outcome that you're using. And so a lot of times for creating predictive models, we use ROC curves, and they're an interesting way to portray the data that you are collecting and give you, a visual idea of your model. And this is looking at 3 scores: the 6 score, the LODS, and the PDS score. And it's talking about how well they performed, and they all did very well I would say in hospital or in rural clinic setting. This is the PDA, the Pediatric Early Death Index for Africa. And these are the different variables they looked at for the score. And the last one is the 6 score. What I want to note in this is they use a pulse ox to see what the SpO2 was. And so you can see these different scores. The first one is just clinical signs. The second one had some interesting jaundice, focused respiratory, and a mental status exam, in addition to malnutrition. And this one is mental status, pulse ox, blood pressure, and just vital signs. And there's also a lot of research being done in using point of care, specifically pro-inflammatory biomarkers. There's lots of different biomarkers that can be used. This is not feasible in the pre-hospital setting, and you can't translate, like I mentioned before, this data to a pre-hospital setting. Ideally, there would be a golden ticket, and that's what everyone would look for. You do a point of care test like a malaria RDT, you do like a capillary stick, and it tells you a number, and then you're like, oh, you need to go to the hospital right now. The kid looks perfectly fine. Little do we know that they are at very high risk for early mortality. That doesn't exist. And although like STREM1 and some of these biomarkers have great ROC or great accuracy in clinic setting, it's there's nowhere near translating this or using this in a limited resource setting right now. There are papers right now talking about how to modify this test into something that could be used at a point of care test in a limited resource setting on like a larger scale, but it's nothing that is going to be done anytime soon. This is just really looking at a multitude of different biomarkers and see what their role in predicting early and late mortality in pediatrics. And this wasn't 2012. I apologize. This is an error. It's 2022. So this was a recent article. So this is the question again. What can predict serious illness specific to this pre-hospital setting and specific to this very limited health resource setting? And so I mentioned the challenges of developing a model in this setting. And then also my interest in global CVPR or global participatory research. How the biggest challenge is infrastructure, which we have, and then we have the CVPR program model in place. So it kind of sets us up nicely to do this research. So for a 18-month prospective observational study we just completed, we worked with 4 community health workers, the y-axis. We had a referral location that had a provider at all time here, which is the kind of the blue shade. And there's 2 regional hospitals, which would take a significant amount of resources to send the patient there. We looked at the outcome of admission to this clinic, in addition to the clinical definition of sepsis, which is a Goldstein's criteria. Our first aim was to see if pre-hospital point of care tests, such as CRP, an advanced point of care test, could be done in a setting without electricity in villages with solar panels. And we created an algorithm for testing if the CRP analyzer could be used. This was successful. The community health workers, as we predicted, given their role in the program that we have, their competency remains very high on all their skills. We predicted that they would equally do well with point of care testing, and they did. This is them 2 weeks ago. We finished the study. They got certificates, and these are the CRP analyzers. As you can imagine, they're now like handheld 2 years later. That they're like small iStat machines, but this is the best I could get from South Korea at the time, and getting them in country was extremely challenging. These are the solar panels they used in their villages, and their competency out of 10 remained near perfect throughout the study. Our second question or aim was to see if CRP, among other clinical variables, could predict admission, mortality, and the definition of sepsis from a clinical standpoint, since we don't have cultures or any other way to really look at other outcomes. And we realized pretty quickly, which we knew, that 700, a sample size of 700 wasn't going to be enough for us to have mortality as an outcome, which will set us up for our much larger study that is starting in a few months from now. And our data from this pilot study was very interesting. Half the kids had malaria. And so right now I just got this data back about 2 weeks ago, and right now we're stratifying malaria and non-malarial sepsis and looking at outcomes differently between the two cohorts. You can see some significance with some of the vital signs. This was for the outcome of sepsis here. And what's interesting is the CRP values for malaria. It's never been done in a pre-hospital setting. So a couple firsts for the study. The first time a advanced point of care test has been done in the pre-hospital setting, specifically by community health workers. And this was also the first time CRP has been done pre-hospital setting for patients with malaria and children with malaria specifically. I don't think it's been done with patients either, but for children, the first time. And so it's interesting to see what the numbers are for the CRP as well. And this was the outcome for admission. Things that are obvious, like if they had a WHO danger sign, we knew that they were going to be more likely to be admitted to the clinic. But as far as our question for the pilot study, we did not find a model with either of these outcomes. We did not find a model that was that had accuracy that could be used for prediction. And so what our plan was and the reason I introduced those other in-hospital scores is to expand the study to a much larger cohort of community health workers, which would increase our sample size. And I'll talk about that right now. And so these were these first two aims of this research that's completed now. And the big limitation was we couldn't use transfer to a regional hospital. We couldn't use a composite outcome to look at like IV fluid resuscitation and oxygen use or mortality because of our sample size. So that limited us. We also couldn't control for the CHWs, our community health workers' exam findings. And so for this, when we expand, we plan to do like a kappa test retest, which means we'll follow two different examinations, the community health worker, and then within a small time range, they have to be referred to the clinic, every patient, and that'll be reevaluated by a provider to see with some accuracy if their exams are somewhat similar. Obviously, there's going to be a margin of error between, I believe, 15 to 20% on the exam findings, but at least we would be able to see if they're lining up, and then also adding in the other variables. And so the sample size going from 4 to 40 community health workers over 2 years would bring us from like 700 to 12,000 patients, which would help us out a lot. And then the variables, adding in the things that we were missing before from the pilot study, like the SpO2, jaundice, mental status, a focused respiratory exam, those things are easy to train to include in the community participatory program that we have, include those in the training, and then evaluate those with the study as it's implemented. And then, as I mentioned before, we'd be able to track the referrals closer, and then also have follow-up within 72 hours and 1 week after discharge, just to see what the outcome was, and look more at a composite outcome that would include some other details, such as oxygen and IV fluid resuscitation and transfer to a regional hospital. This is the big picture. And so putting all of this into context, what we want is something more than expert opinion for when to refer children early. It takes an incredible amount of resources for families who are in poverty or extreme poverty to refer patients to a hospital, or in Uganda, it would be like a level 3 or 4 health center that has, resources to treat their child. when they do put those resources, it can be a huge burden. And so we want to find a way to have some objectivity to pediatric referral in the limited, the low to middle income regions of the world. And this would be by modifying what the ICCM does right now, which is not evidence-based, or has a low grade of evidence base, I would say. And so by expanding this algorithm that we have before, we hope to be able to create something that can be used to predict which children are at high risk for referral and create a model similar to like the danger sign current model, but based on clinical variables such as vital signs, exam findings, and possibly a point of care test. I don't think CRP is going to be the right test. We'll see once we stratify malaria if it was helpful in this pilot study. But our objective was to prove that advanced point of care tests can be done in a region of no electricity, and it can be done successfully by someone with no formal healthcare training. And that was very successful. And so that was exciting. These are the variables that I mentioned before that we'd be adding to this new study. And this is portraying what a community model would look like from a training perspective. I'm on the outside, standing there, not really doing much, providing some oversight or answering questions if needed. But it's really a train the trainer model where the trainer is leading the instruction, and while we help provide resources for this model to continue. And then eventually one of the trainees would continue after years of competency to advance their career into more an advanced VHT, and then hopefully resources would be available to continue their career in medicine to something that they want to pursue, if it's something they want to pursue. As Dr. Roy mentioned, I'm on a T32 through the NIH. I'm on my second year right now, funding through that. My mentor is Dr. Capello at Yale, and I've been applying for K23 awards. And I'm not sure if any of this means anything to anybody. If anyone's pursuing a kind of an early career NIH award, but some of the language can be really challenging through the NIH. This is an early investigator award that would provide 5 years of funding to continue this research and protect me clinically. Right now, I work about 50% in the ICU, and the rest of it's protected through the Peds Scholars Grant and the T32 for me to do my research, but that expires. And so it's kind of, when you're in research, as many of you know, you're kind of on the clock. And so this would buy me the time I need to fulfill my career objectives. Also in pediatrics, we have POLICI, which is a group of, it's a pediatric acute lung injury group that looks at data across the world to provide more evidence-based care for children. And there's a subgroup that works in global health. And so we have a large subset of data we're looking at validating some of the in-hospital predictive models or creating a new predictive algorithm for what's kind of been used at a lot of different clinics from this large data set, and see if the same models that I mentioned before, including other ones. There's about 12 to 15 models. I saw a couple of new ones, so I say there's more than 12 that have been used in limited resource settings and clinics that have not been validated in other settings. And so with having this very heterogeneous group of, or subset of data, we can look and see how these models would perform. And then we have a CBPR program looking at soil transmitted helminth control in Guatemala, which I think I mentioned earlier. But that's my talk. I would like to open it up for any questions. I know that I went maybe a little bit fast, but I hope this was interesting, and I would love to answer any questions or collaborate with anybody who's interested. Thank you.
Thank you so very much, Dr. Ebbs. That was fascinating. Anybody from the audience have any questions? Oh, Dr. Jackson?
Thank you, Dr. Ebbs. That was awesome. And I just so applaud, what you're doing and your dedication. It's just, it blows me away. So thank you so much for all that you're doing. I do have a comment. I don't know if you're going to be able to attend our IBRS, which is our interdisciplinary biomedical research symposium, which is next Saturday on November 11th. It is in Kirksville, and we do have an online opportunity. The keynote speaker is Dr. Dennis Black. Dr. Black is a gastroenterologist pediatrician, and he is an expert in getting all different kinds of awards through NIH. And so his keynote talk is going to be kind of about how do you go about this? How can you strengthen your proposals and so forth? So if you have time to join, I know you're super busy, traveling the globe, but if you do have time, you might find it beneficial. And then to connect with him, I can also hook you up with Dr. Black, and maybe he can, if you have any questions about NIH, the particular K-23, I know he's gotten a number of those, of the people that he mentors awarded. So I just offer that up. And then if not, there's always the online after the fact, we'll present everything. I don't know if it's on Zoom or where we'll post it, but it will be somewhere. So.
Excellent. Yeah, I would love that. Thank you so much. Appreciate it.
Welcome.
So I'll just pop in a couple of questions myself, and then there's enough time for others to pose theirs. I have two questions where basically it might be a little threadbare, and so bear with me. How do the community health workers reach patients? How are they conduiting?
Yeah, it's a good question. So they're appointed by the village chiefs, and then the community recognizes that a VHT is like the health advocate or representative of the community. And so anytime someone's sick, this has been studied before, not in northern Uganda, but what percentage actually go. A lot of it's dependent on the proximity to a health post. And so community health workers are generally strategically placed in very kind of more rural. And that's kind of why northern Uganda is a good spot, because we choose areas that are they're in their community and not an area that would be easy to access a health center, although there are lots of health centers around the different regions. But most patients, over 70%, go to the community health worker first, but you do miss a percentage of that don't go. But those numbers too are really difficult to ascertain.
Thank you for that. I have another question. What other diseases contribute to high mortality other than malaria, apparently, in this area? And can you have them be kind of adapted to those as well?
Yeah, I do a talk on pediatric mortality from a global perspective, and it's really fascinating. But a lot of it comes down, that's why I use sepsis as an outcome, because it is over 50% are things that are of infectious origin. And so, this all gets back down to having basic supportive care. Every time I round when I'm at the clinics in northern Uganda, over half of the children have malaria. And so it's a combination between malnutrition, malaria, and pneumonia. Basic viral pneumonias caused from things in the community take a huge toll on kids because they have those underlying comorbidities with the severe malnutrition, just from the diet and the poverty, in addition to malaria just being so endemic to the area. Even with the vaccine coming out, it hasn't reached them yet. Hopefully in the next few years that the malaria vaccine will. But the WHO does a good job at stratifying the what's killing kids, and most of it's infectious, although there is a lot more trauma percentage wise in these areas, just because of the things that we normally use to to keep ourselves safe, like buckling seatbelts, having maintenance on vehicles, and wearing helmets are they don't cross over as well.
Thank you.
Yeah.
I have a question. I have a pastor friend who's an attorney, and he is an attorney in Uganda. And he goes and he helps children that have been kind of attacked by the medicine men. I guess that's what they're called. So I'm curious if you have encountered the medicine men kind of culture, and how you, if you have, how you've interacted with that.
Yeah, there's Uganda is very complicated because it was war torn up until about 10 years ago. And so every time we start a meeting, everyone thanks the group for it being peaceful and prays for like a peaceful time, because it's so ingrained to the culture, especially in the north with the LRA that was there for so long. And the country was in a state of emergency. This isn't answering your question specifically, but there's warriors still on the borders that come through, and will frequently there's kind of like small insurgent groups along all the borders, and that's why you can't travel at night, and it still can be dangerous in those parts. From like a shaman medicine man standpoint, that might be more specific, I think, to the Northeast region. So it kind of depends on where he works. In the North, where I work, it's more of, they call them warriors. And the warriors are like a nomadic group that steals cattle and robs people. And they're constantly at battle with like South Sudan and Kenya neighbors on like kind of more tribal warfare. But I haven't heard specifically about to answer your question about the medicine men, or the shaman they're attacking. At least not the area. It's a big country. It's not a big country in respect to the US, but I kind of go to my own geographic region.
Right. Yeah, thank you. It's fascinating, and it's just amazing what you're doing. It's amazing.
Yeah, it's thank you. It's easy once you go there and you see the need, and then like the physicians I work with there, their experiences are just incredible, and so it's nice to support their training and their research as well.
Any other questions from the audience? Well, I believe they're just spellbound, so they don't have any questions. Having said that, I wish you best of luck for getting the target samples you need to get those very specific AUCs, and I hope to see you again with us, preferably in person in Mesa one day. And
thank you. And let me know, give me feedback on if you want it more statistic heavy. I can do that too. I try to keep it more superficial from the predictive modeling standpoint. But I can always go into more of that if that's ever requested.
No, this is amazing. Like, you're building something from, like kind of like you do have like a basis with your graduate project, but you're building something up, and that's fascinating. And keeping your sites open on newer variables, that's exactly what we should be doing. So thank you for that, and we will see you soon, Dr. Ebbs. This is amazing. This is amazing. Thank you for mentoring. I forgot to mention Dr. Ebbs mentors tens of students every year from summer. So
it's no problem. It's a privilege, and thank you so much for allowing me to present. And anytime, I would love to help with anything.
Thank you, Dr. Ebbs, and thank you everyone for joining today. And we'll see you sometime in December.